depends on the medications that you have available. What is the patient's heart rate, for instance? How fast are they declining to help you choose any further agent? So I think you'd be hard pressed to find any further guideline evidence that one agent should be chosen over the other. What if they have hypotension associated also with low cardiac output? I think it's pretty clear from the evidence that if it's a bradycardia alone, a chronotrope is very reasonable. In a patient who is normotensive and in cardiogenic shock with high SVR, these are the patients that you want to use an inodilator or possibly a vasodilator. Here at our institution, we use a lot of milrinone and nitroprusside in these situations. But again, really, there's no superior agent with any proven mortality benefit. There was the recent Doremi trial, which looked at dobutamine versus milrinone, and there was really no difference in major outcomes, such as mortality, the need for renal replacement therapy or transplant. And it's really about using IV vasoactive medications titrated to support perfusion. What we employ at our institution is trying to use a multimodal approach. So we'll use multiple different medications. So for instance, in a patient who has the hypotensive phenotype, using some norepinephrine as well as vasopressins to minimize the adverse effects of high-dose norepinephrine in particular. So what if pharmacologic therapy alone is inadequate? That's when we have to consider employing temporary mechanical circulatory support. And at an institution like Vanderbilt, we're dealing with a lot of cardiogenic shock patients. We, for better or worse, have to employ a lot of mechanical support in order to be able to bridge our patients to transplant or for a destination VAD if that's an option for them. So we have a number of different platforms available to us. So I'll just speak on them briefly just to give you some familiarity, but I'm happy to ask to entertain any further questions if you have any. So for primarily our right ventricular support, there are two platforms available. We have the Impella RP Flex, which is a microaxial flow catheter, as well as a percutaneous RA to PA VAD, which helps really just offload the RV by draining blood from the right atrium and then putting blood flow into the PA. And this can be the RA to PA PVAD can be used in concert with an oxygenator in a patient who also has lung failure as well or a degree of congestion. For primarily LV support, I'll direct you to the last three platforms. So we have the intra-aortic balloon pump. The balloon pump as is utilized, has often been utilized for early ACS or LV failure, inflates during diastole to provide adequate coronary perfusion and decreasing overall afterload by deflating in systole, and is thought to provide a modicum of forward flow in terms of augmenting cardiac output. I think this is our lowest level of LV support, and if it's inadequate, we'll really reach for either an Impella CP or an Impella 5.5. So this is the corollary for the Impella RP, where it's a microaxial flow device that provides blood flow that drains the LV and pushes it out into the aorta. And if you've got both RV and LV failing, that's when we will utilize VA. And in VA ECMO, you're draining from the right atrium and placing it into the aorta and bypassing the heart entirely, in which case you need to place an oxygenator, so you're also providing a degree of lung support. Moving on to critical care management in cardiogenic shock patients, really it's when you've got to utilize all of the aspects of best practices in critical care management. Intensive monitoring, using frequent lab monitoring to look at signs of end organ perfusion in concert, I think, in the modern ICU with frequent echocardiographic assessments with your point of care ultrasound. And that's because we've got to monitor for a lot of the negative sequelae that may happen in the setting of cardiogenic shock. We've got pulmonary complications as a result of congestion. They may need support with the ventilator, and that puts them at risk for ventilator-induced lung injury, ventilator-associated pneumonia. These patients, as a result of their shock state, are going to be lying in bed in the ICU, are going to develop weakness and critical illness, neuropathy and myopathy, neurological complications such as delirium or stroke. As a result of the medications or the interventions you have to do, they're going to be at risk for cardiovascular issues, arrhythmias, vessel perforation if you need to place any of these devices, air embolism, tamponade. And then, as a result of being exposed to the ICU environment, being critically ill, they're going to be at risk for ulcers, GI bleeding, bacteremia, hyperglycemia. And these are all things that need to be monitored well by a multidisciplinary team in the ICU. So mechanical ventilation is often required in patients in cardiogenic shock, and this is usually due to either severe hypoxia. They've got high work of breathing due to, the acidemia that can develop from low tissue oxygenation, or they can just be really unstable. If they require a high degree of vasopressor or inotropic therapy, the shock may affect their mental status. And then there's also a possibility that they just need to be intubated for a potential procedure that they need as a result of what precipitated their cardiogenic shock, such as an MI. And this scenario happens pretty commonly. You have a patient who comes in with a STEMI. They are so congested they can't lie flat in order to undergo a catheterization procedure. So they may need to be intubated for that. And we know there are profound cardiopulmonary interactions that can affect overall hemodynamics. Because when you put a patient on positive pressure ventilation, there's going to be profound changes in how blood is delivered to the right side and the left side. So, with positive pressure ventilation on inspiration, you're going to have decreased RV venous return. You're going to have increased PVR due to vascular compression, RV dilation potentially with left shift of the septum in the setting of ventricular interdependence. And you may have a compensatory increase in systemic vascular resistance. The positive pressure ventilation can also affect your left ventricle. You've got a decrease in preload due to your lower RV output, and stroke volume can go down due to the interventricular dependence when you've got changes and shifts in your interventricular septum. And this can lead to overall LV, a decrease in LV afterload, which actually can be beneficial, but the decrease in LV preload and the LV dilation can result in an overall decrease in your effective cardiac output. And the overall net effect of PEEP on cardiac output really depends on their RV, their LV function, their preload, afterload, and ventricular interdependence. And in certain cases of RV failure alone, if you're trying to optimize PEEP, do a best PEEP trial to be able to adequately oxygenate, patients who've got RV predominant failure may really not be poorly responsive to incremental increases in PEEP. So it just has to be kept in mind that even a bedside recruitment can result in profound changes in their hemodynamic profile as a result of this therapy you've utilized to help with their end organ oxygenation. A usual initial ventilator strategy, I think it depends on what your comfort is. There's really no best mode of ventilation. I think it's reasonable to start with a high FiO2 in the setting of the throes of cardiogenic shock, and then titrating it down to an FiO2 that maintains at least normoxia, tidal volumes that are lung protective, as well as a minute ventilation that ensures that they have a normal pH. And with adjusting PEEP, if your wedge is between 12 to 15, starting with a PEEP of 5 to 10 is reasonable. But if your wedge is very elevated, PEEP can be increased while monitoring cardiac output after a judicious recruitment maneuver. Like we had mentioned, cardiogenic shock has profound impacts on the healthcare system and provides significant burdens to a healthcare system. In the United States, the annual cost associated with cardiogenic shock exceeds 65 million, and this is due to hospitalization costs. These patients have prolonged ICU length of stays, and there's a lot of resource utilization for all of these complex interventions. I think some unique challenges that you may face in Kenya is that if you have a patient that declines with pharmacologic therapy, you may have limited access to some of these advanced medical technologies. I'm sure there are certainly financial constraints. These advanced medical technologies that we're discussing, Impella, ECMO, you know, for us, they are incredibly expensive, and we want to employ them mindfully in patients. And not only are they, but they take up a high degree of healthcare resources. It requires a nurse that's familiar with them, a medical team, a multidisciplinary team that is comfortable with being able to manage these patients. And this is not something that can be employed in all patients because that would present, a number of logistical challenges. So some updates for cardiogenic shock, particular to LMICs. I think the biggest takeaway here is, I think the introduction of point of care ultrasound for for easy bedside use in the ICU has really changed the landscape of how we can evaluate these patients early to identify their potential etiology of cardiogenic shock and help also stratify which stage they can be in addition to your physical exam as well as the lab work. The initial management in a lot of ways in terms of pharmacologic therapy is very much the same. You want to use your vasoactive agents, you want to address congestion. And then I think talking about a multidisciplinary shock team that helps with early identification, that potentially even transfers them to a center that has expertise in shock management, whether that be because they have easy access to a catheterization laboratory or more familiarity with using invasive hemodynamics, I think is what can be helpful um, in moving the needle with outcomes. So, we talked about the Suspect CS algorithm for diagnosis. That's something that can be used. Point of care ultrasound is something that we are actively trying to do, and I think Matt has been working on this, and I'm sure a number of you have been to a conference where you're working on utilizing echo and point of care ultrasound to early diagnose all kinds of patients. And you can see clearly that it can be helpful in the setting of cardiogenic shock. And then really developing a team that can deploy resources that are reasonable and appropriate quickly to help manage. And not all cardiac centers are going to be able to adopt these advanced tools immediately, but I do think the thing that they can do is develop a care team that uses an interdisciplinary approach to ensure that best practices are utilized for rapid identification and triage for cardiogenic shock patients. And that means a patient who may be at Sky Stage A or B, knowing which patients that they are so that when they progress to Sky Stage C, that they can be appropriately triaged to cardiogenic shock specialized unit like an ICU. And this really requires some specialized knowledge across multiple disciplines and speaking with other members of the hospital staff, because this is really what can potentially improve patient outcomes. Yeah. Some more recent updates in shock management. There have actually been several high impact publications that have defined cardiogenic shock even within the past year. The danger shock trial was looking at patients who developed STEMI that progressed to cardiogenic shock. And that trial looked at using the Impella, which is that microaxial flow pump. And it has continued to show that potential early utilization of the microaxial flow pump can be beneficial. Understanding the cardiogenic phenotype can help shape which device you use and which drugs are employed. And then real world registries are helping highlight the gap between trial data as well as the practice data, because a lot of the trial data that we are using to help guide, develop the guidelines for cardiogenic shock management have excluded a lot of patient populations that we're all used to dealing with. For instance, the danger shock trial, as I mentioned, showed a mortality benefit with early adoption of the Impella in STEMI patients, but at a cost of more complications. It does require access to femoral artery. The Impella CP is a 14 French catheter and a femoral artery, and you can imagine that placing a 14 French arterial catheter in a small patient's femoral artery can lead to end organ damage to their leg, can lead to limb ischemia, can lead to vascular complications that we want to avoid. There have been two recent secondary analyses to refine who really benefits. And non-congested patients with cardiogenic shock, so those patients who come in without, the rales, pulmonary edema, had the greatest benefit from an Impella. And those patients that had already developed metabolic or cardiorenal effects, there really wasn't a clear benefit. So not every STEMI patient needs a microaxial or an Impella, but I think this is something that you're going to see increasingly utilized. And we're certainly seeing this here, even for procedural support to help bridge patients who come in with MI. And then I think there have been a number of new registry data looking at how we monitor and regularly assess patient hemodynamic profiles. And to help really shape which patients may benefit from different kinds of interventions. And I'll highlight for you here the ALT Shock 2 utilization of an IAP balloon pump was linked to higher mortality in ACS. So we're really seeing the intra-aortic balloon pump fall out of favor, particularly for this patient population. And then I'll tell you anecdotally from working in a heavy heart failure center and a heart failure unit that we're using the intra-aortic balloon pump a lot less in favor of the microaxial flow pump or the Impella. So in summary, cardiogenic shock is complex, it's high risk. Helping get together a team to help manage these patients is really critical because morbidity and mortality remain high. Early recognition is important to help triage them and find the right intervention for them. And a team-based approach really matters. Standardized interdisciplinary care, I think, is really what helps improve outcomes and guide care transitions. So I want to thank you for your attention. This is me from a number of the different point of care ultrasound courses that I've given over the past few years. I hope I'll have the chance to do some more in Kenya in the near future and practice my Swahili. But thank you so much for your attention and for letting me share a little bit about how we managed a cardiogenic shock with some of these tools that I think the data for which how we use it and when we use it is still really up in the air and rapidly changing. I'm happy to take any questions.
Thanks, Christina. Thank you for an awesome talk. For the audience we began bang on time. I was telling Christina about Kenyan timing, but we started at 6 o'clock. For those of you who
Yeah.
missed it, she's Associate Professor of Anesthesiology at Vanderbilt University Medical Center, and she's currently at work babysitting a heart transplant.
Yeah.
That's what she does. That's the easier part of her work. She wasn't able to put her speakers on for the Zoom call. She's been to Kenya before in her 20s, has done some work, a lot of POCUS work in training in Ethiopia. So she really is the intersection of cardiac anesthesia, critical care, point of care ultrasound, ECMO transport, global health, education, and she scales mountains in South America on her free time.
That's right.
So let me see. If there's nothing on the chat, I'm gonna go ahead and maybe just try and keep it like I suspected the audience is quite diverse. So let me try and keep it a bit light and existential for now. I'll stick away
Yeah.
from the impeller for now. Yeah.
I
So
love light and existential.
you like it, yeah? So let's see. Let's go. So when I see your profile as ECMO transport, for example, like direct
Mhm.
ECMO transport, if I bring it down to us, or not sure down to us or up to us, um, what have transport medicine and like retrieval systems taught you about time-sensitive shock care? Because when I think of Sky, I mean, arguably Sky, I would imagine would perform so well in LMIC because it's
Mhm.
very heavy on clinical and not so
Yeah,
much of gadgets because I guess it's
yeah.
about identifying. So I don't know when we think, I know you've been in this in our settings before. So transferring or escalating to an ICU. So when that actually involves a physical transfer out of an
Yeah.
institution to another, what does that look like? What has to come together for that to work?
Yeah, so this happens a lot when we have a patient that is referred to from an outside hospital, and they may be declining fast,
Yeah.
and they don't have the options for the escalation of support that we have here at Vanderbilt.
Okay.
And usually these patients are in pretty bad shock. They're on high dose inotropes, they're on high dose vasopressors, they're usually intubated and sedated, and they've exhausted all of the resources that they have available to manage these patients. But they're a young patient. They want to get to the point where they can survive this. So that's really where the ECMO transport comes into play. So what I'll do is I have a team that includes a perfusionist, and we'll go out in usually an ambulance, sometimes a plane to go to that hospital, and then we'll put the patient on ECMO at that hospital and then bring them back to Vanderbilt. And the reason we do that is because if we put that patient who's, on rocket fuel, barely surviving, and we put them in on an ambulance on their own, there's a high chance that they're going to die. I think that the main value of having this ECMO transport is one, we can provide ECMO support. And ECMO is not a treatment, it's a tool. It's a tool that helps provide and organ perfusion, really tissue oxygen, so that we can bring them over here so we can consider them either for an advanced therapy, just bridge them while, like for instance, a viral myocarditis, if we give them some time, or a Takasubos, a little time, we support their heart with the machine, they might get better. But if not, then it gives them a bridge to which they can get to transplant. And I think the benefit of having the ECMO transport is also the fact that they have an intensivist, me or one of the members of my team, be able to go and assess the patient there. Because there are times when we're called to go and evaluate a patient, and we get there, and the patient's lactate is 9. They're dusky, they're purple, their kidneys they've been anuric for hours. They've now developed a coagulopathy, which is concerning that their liver has also failed. You put those kind of patients on ECMO, they're not going to do well. Their chance of having more mortality is really high. And we don't necessarily want to employ this tool on everyone. So using it mindfully so that we're employing it on patients who have a good chance of survival. Having said that, it requires a ton of resources. Like I have to be available. We need an ambulance or a truck. We have two nurses that go with us, a driver, a perfusionist, and then I also have one of our fellows come. So it's an incredibly resource intensive tool. But I will say, given the growth of our lung transplant and our heart transplant, we are able to bring more patients from all around the South, from our area, essentially, to be able to come to our institution to be transplant candidates.
Okay. Okay. So what I was trying to think is to bring it down. I don't bring it down to where
Yeah,
we're not even trying to get a patient to
yeah,
ECMO. We're just trying to get them to a critical
yeah.
care setting. And so, well, like you just said at the end, you have all these players. So you have sort of the human resource, you have the tech, you have many things logistically have to come
Yeah,
together to make that
yeah.
work. Yeah,
But
to
I
make
think
that
it's
work.
also like
Okay.
I'm sure a lot of the centers you're at, you have specialized centers that have more familiarity with dealing with different kinds of shock, that have more
Mm-hmm.
ready access to labs to
Mm-hmm.
be able to even
Mm-hmm.
get a lactate. I'm sure can be challenging depending on the different institutions. So in a patient who is young, in a patient who you think can you be able to get through this, I think it also takes coordination with the referral centers.
Yeah.
If you have a patient who's in Sky stage A or B,
Mm-hmm.
maybe consider, if you see evidence of decline, sending them to our tertiary center, which is going to just have more resources to be able
Mm-hmm.
to manage them, to have
Mm-hmm.
the benefit of a multidisciplinary team. I think that's really where the future of really coming to advance cardiogenic shock care really will be. certainly for Ethiopia, for Kenya, is building the referral network so you can get them to
Yeah.
an institution that has the benefit of early diagnosis, recognition, and management. And management doesn't have to include ECMO. Management can include appropriate use of, inotropic support, being able to
Mhm.
monitor for the negative sequelae of all that.
Mhm.
I think it is all really important.
I'm going to ask an unfair question because I'm not sure if it has an answer.
Okay, I'll
If there's
try.
any data around it, I'm not sure if there's any data about it. But I'm wondering, like, again, like looking at Sky and looking at all, like, I think the earlier gains of early identification and escalation,
Hmm.
interventions like POCUS and things that really are scalable in our setting, which I think
Hmm.
you are involved with, and it looks like,
Yeah.
I think it seems like POCUS is far more scalable than a lot of
Yes,
hemodynamic monitoring, for example. I haven't touched a Swan
absolutely.
scan in almost 10 years.
Yeah.
Um, do you imagine that that's an opportunity to change the trajectory of pathology by catching some of this earlier than the conversation around LVAD and Impeller,
Yeah.
sort of like he stayed away a bit if you can get the earlier part correct or get it right.
Yeah, and I think there's other elements of POCUS that I'm happy to talk on at a later date. But POCUS isn't just looking at the heart. I think looking at the image I showed you is looking at the heart, but you can also use a point of care ultrasound to look at some of the level of venous or vascular congestion. So for those of you that are familiar with lung ultrasound, looking at B lines, looking for uh, pleural effusions, these would be some of the end organ sequelae of having an elevated, for instance, pulmonary capillary wedge pressure. And so not only can you diagnose that a patient has end organ congestion by using your lung ultrasound, evaluating, oh, they've got, a bunch of B lines in the posterior lung fields. What you can actually do in addition to diagnosing them is if you diagnose them and then institute treatment, so I'm going to start a loop diuretic, and then you can follow your lung ultrasound over time. Do I have resolution of B lines? Do I have return of A lines? That's one area where I think you can really utilize point of care ultrasound, not only cardiac, but also lung ultrasound. And then there's also something called VEXUS, which is our venous excess ultrasound, and that's looking at the venous waveforms in your hepatic, portal, and renal venous system to assess whether the patient is congested. And this actually has a changing phenotype that will alter depending on their level of congestion. So if you've got, for instance, and I'm sorry I didn't really go into this, is if they have evidence of tricuspid flow reversal, for instance, that can be a sign that they're very congested and you might want to institute heavy diuresis, and this will change. This is something that you can follow over time, just like your lung ultrasound, to see whether the effects of your preload modulation have actually been effective.
Sorry, nice, nice. I think we have. I'm being prompted that it has to. We're almost done in 5 minutes. I'm
Okay.
just gonna keep going with the questions. I don't. I think I don't know, the audience, you must have been very clear.
Yeah.
A bit of a silent audience, a shy audience today. So, in your institution, do you have like a shock care team? Like, is there an institutionalized shock system? And what does
Yeah.
that, and if you do, from your work in Ethiopia, are you building a shock team? Or what does that look like? How do you get there? What should that look like?
I'll tell you, we have really struggled. We
Yeah.
have a lung failure team that has been very effective. Our
Hmm.
shock team has not been so effective. But
Hmm.
one thing that I thought really worked well I was in New York City for a time during COVID, and their shock team consisted of all of the members of the team who,
Hmm.
all the consultants and intensivists. There were like 12 of them. And when there was a patient they were worried about, they would all get together on WhatsApp and say, "Hey, this patient's lactate is this, and this is their hemodynamic profile. What should we do next?" And they would just kind of talk about it. And I think having a system like that where you have an avenue where you can talk together with a patient and get multiple inputs, it is something that we have not done very well for our shock system. And I know some of the other shocks I do think, all it takes is having a platform to communicate and having a common language to be able to be able to talk about the patients. And what I mean by that is, for instance, when we have a patient who is having a declining respiratory status, what we'll do is a text goes out to all of our members of the team. We all log into Zoom or Teams. One person presents the data in a methodical way. So here's the patient's name, their BMI, their size, their respiratory status. So what vent settings they're on, what's their FiO2, what's their arterial blood gas, how long have they been this way, what are their other comorbidities that affect management, and then we just discuss together. And usually it can take anywhere from 15 to 30 minutes. But it gets all the members of the multidisciplinary team to decide, the further management for that patient. And, to be fair, that is for management of whether we need to institute any kind of advanced therapy. But I think getting multiple members of the team together is something that can be done really anywhere. Having one eye on the patient, just one consultant, I think is the way that things have kind of always been done and has value is less resource intense. But there's avenues for collaboration that I think we're still figuring out the best way to explore it. We haven't figured it out yet, but I think that's something that can really be done anywhere.
I don't know if misery loves company, but it's really
Yeah,
wonderful to hear
right. That's right.
That Vanderbilt is struggling is so good
Yeah,
to so good for
we love
myself.
misery and company. So
We love misery and company. Yes, yes. So I don't know. Honestly this is has been very eye-opening for me because I mean you think cardiogenic shock, I'm a cardiac anesthetist. I mean that I was thinking deep into phenotypes. This it's so much evolving in this
yeah.
area, obviously, so much conversation. And really is cutting edge. But I
Mhm.
like that your talk really grounded it and brought it down.
Mhm.
To things that are translatable and we can use and they're important for our patients. And I feel like the audience, I know for myself, I'm going away with a lot of takeaways and a lot of hope. How we can improve our systems because it sounds like
Yeah.
cardiogenic shock, like most things. I mean, it's a complex clinical scenario, but it's
Yeah.
systems, it's logistics, it's training, it's all those things coming together. I see somebody asking a question.
That's a
Sorry.
great question from Ronnie. AI,
Yeah.
he asked, have we adapted any
Yes.
AI systems to assist care? I think
Awesome.
this is really the next step. And, I've been to a number of meetings. We had just had our cardiac anesthesia meeting, our critical care meeting, and AI is everywhere. I think I think the best way to use it is to use it early and find out how we can best utilize it in our system. I'll be honest with you. I am a late adopter. I'm probably the last person you want to ask about this, but I know that AI is here. We've got to figure out a way to get used to it and how to best utilize it. I think how that's going to work in every different specialty, including in heart failure management and cardiogenic shock, is still to be determined. But this is, the fastest area of growth. It's not something that we utilize yet. But in terms of pattern recognition, in terms of understanding which stage they're in, like this is something that AI could probably easily do, particularly if a lot of this information is available within a computer system. We have Epic, which a lot of different healthcare systems use in the United States. All of the information is there. And I think having tools that signal, okay, this patient is at high risk, take another look is something that would be kind of the lowest hanging fruit. But I think, man, the next 5 to 10 years, seeing how AI is going to affect how we take care of patients is still really unknown.
Brilliant. Thank you. Thank you. I'm trying to get my video on.
No, you're
So,
good.
yeah. So, Christina, are you open to anyone reaching out to you for more questions, to collaborate, to get some of your advice, some of your
Yeah,
insights
absolutely.
on your
I'll put
work?
my email here in the chat.
Yes,
I'm
please.
happy to
Yes.
take any questions.
Yeah.
Or anything. I really appreciate Angela. Thank you so much for your excellent moderating. Thank you so much for having me. It's been a pleasure to talk about something I care a lot about and
Hmm.
talk about a little bit about how we do it here at
Yeah.
Vanderbilt and letting me share with you. It's really been an honor. Thank you.
Thank you. Thank you, the audience, for listening in. Thank you for we had a whopping 150, almost 160 people logged in at one point. And thank you for paying attention and taking all the insights from Christina. Christina, thank you for your time. And I think we'll have a good night.
Okay, thank you. Take care, everybody.
Okay.
Have a great
All
night.
right. Bye. Good night.
Bye.